I'll start with the MIGS in angle closure. And is it worth enough to go into an angle and do a procedure when there is not enough space, or is it going to cause you pain? And very happy to be a part of this group again. Now, what are the challenges in performing a MIGS when you have a close or a narrow angle? The first thing is access to the Schlemm's canal and iris root. And it will really depend on the extent of synechia that you have and the lens vault and the largeness of the lens, whether it can actually access the angle at all or not. The nature of the iris that we Indians have is different from that of the white population. I know of people who don't do peripheral iridectomies with their traps and are quite comfortable with it. They don't get blocked. I had one of those surgeons come to India from Canada, and first 5 of her trabeculectomies that she did without a PI, they all got blocked. So we have different iris. And very likely if you go and touch this iris for goniosynechialysis or any manipulation, you're likely to end up with much more inflammation and chances of having a pus forming in the Schlemm's canal that you have opened. A large population of our angle closures are plateau iris, and there doing a goniosynechialysis may not be enough to reduce the apposition and subsequent synechia formation. Now, Dr. Asrani is looking with frowned eyes at me, and I'm a little scared presenting about MIGS and MIGS, especially in angle closure, while he is in the audience. But I'll tell you something, that there is a systematic review that has come up, and I believe it has come up just for me. And if you had read this, you would have not come to listen to this talk. The good part of this review is that they have included studies only which had at least 12 months of follow-up. And of the studies that they have included, 3 are randomized controlled trials. Now, what did this meta-analysis find? They found that phacoemulsification, when combined with MIGS, led to an intraocular pressure reduction of around 10 millimeters of mercury and two medications overall at the end of at least 12 months of follow-up. All the MIGS did well, but if you can look at the graph, GAT probably did better than goniectomies, which did better than eye stents. Now let us look individually at the 2 RCTs. Now this is an RCT which you see the names involved will tell you that it has a very wide spectrum of populations, largely in the Southeast Asian population and centers. And they not only took up phacoemulsification, but randomized between phacotrabs and phacogoniectomy, and had 65 and 59 eyes assigned to each group, large number of which followed up till the end. They also gave you the intent to treat as well as the per protocol analysis, and both of these show that the intraocular pressure at 12 months and the complete and qualified success in both these groups were not different from each other. So the phacogoniectomy did as well as the phacotrabeculectomy in their study. The same thing is reflected in these graphs when you look at the intraocular pressures and the number of medications that these eyes are on. This group from Egypt published a very nice paper with more than 90% success of GAT, and they did a randomized controlled trial where they divided patients and assigned 36 and 38 eyes to phaco-GAT and phacoemulsification. And what did they find? At the end of their follow-up period, phaco-GAT did much better than phaco alone, and the success rate was 95% versus 87%, and the number of people or eyes which were off meds was significantly different in the 2 groups at 75% and 42% at the end of 1 year follow-up. Our experience is not evidence because it is not published, but I'll just share it on how this is fared. I will skip the videos, but you can see that this is an eye with uveitic glaucoma or superimposed on angle closure where I'm doing a synechialysis. This is an eye where a KDB is being performed. So just presenting the data which we are working on. 48 eyes of 41 patients, 40 of which were PSCGs, followed up for at least 6 months. Success was defined as intraocular pressures of 21 millimeters of mercury or less, along with at least 20% of reduction, along with reduction of at least 2 AGM. So it's a very strict definition in terms of looking at success of MIGS. 3 of these eyes underwent MIGS alone. Most of them were combined with phacoemulsification. 23 of these 48 eyes had a follow-up of 1 year or more, and 95.8% eyes met the criteria for success. Intraocular pressure, the mean intraocular pressure, the standard deviation is a little higher, dropped from around 23 to around 13. Medications from 4 to 1, and 85% of eyes had intraocular pressure less than 16, with 65% of them being less than 14. 23 eyes of the 48 were free of medications, though 2 eyes needed further glaucoma surgeries. At the end, in my opinion, and it's only my opinion, one has to consider that if you want to do a MIGS in these eyes, you have to look at the degree of PAS, whether there is plateau iris or not. Contribution of lens is very important and is always better if you're going to do a surgery to combine it with phacoemulsification. Always look at the extent of disc damage, because if the intraocular pressure is in low teens, you are not going to most likely get it, or definitely not going to get it over many years, and you are likely to end up in mid-teens. There is promise as far as Schlemm's canal procedures are concerned, like stripping and goniotomy. Minimally invasive bleb surgery, we have to wait and watch. Combining with phacoemulsification is a very good idea. And whereas the Schlemm's canal implants are concerned, like iStent and Hydrus, I would be very conservative in recommending them. And of course, opinion and RCTs are invited. Thank you.